welcome everybody to this afternoon session. My name is Dr. Michelle Howarth, and I'm a senior lecturer in nursing at the University of Salford, but I'm also one of the steering group members of the Social Prescribing Network and one of the committee members for this conference, and I lead the National Special Interest Group for Nursing, Midwifery and AHPs around social prescribing. I'll let Carolyn introduce herself and then we'll make her start.
Hi everyone, I'm Carolyn Wallace, Professor of Community Health and Care Services at the University of South Wales and something called Prime Centre Wales, which is the Welsh Government funded Primary Emergency Care Research Centre. Within that sits the Wales School for Social Prescribing Research, and I'm Director of the school. And I'm looking forward very much to your presentations and to the Q&A afterwards.
Okay, thanks Carolyn. So we're both co-chairing this session this afternoon, so as you can imagine there's lots of people at this conference, so it takes two to co-chair these sessions, but this session is going to include 4 presentations that have all explored key aspects of social prescribing. As for other presentations, we'll introduce each one in a running order, and the links are in the chat room. If for whatever reason you struggle to see the presentation on the Teams, you can actually click on the link yourself and watch the link. After the 4 presentations have completed, we'll then open the chat room for question and answers, and I think 3 out of the 4 presenters are here at the moment. Hopefully Matthew will arrive later on, and we'll all be here to respond to your questions. Please can I remind everyone to switch off the cameras just so that it doesn't distract everybody, and also make sure that your mic is switched off as well. So without further ado, I'm really glad the technician is probably in the room now. I'm going to introduce our first speaker, and our first presentation is Henry Aughterson, Dr. Daisy Fancourt, Dr. Louise Baxter from the University College London. And they're presenting their research called Social Prescribing for Individuals with Mental Health Problems. And it's a qualitative study of barriers and enablers experienced by general practitioners. So I'm going to click the link, be quiet, and look forward to listening to this presentation. What's happened there? I think what we might do is move to the next video, which is the RESPECT video.
Today we're going to present our study, the RESPECT study, which is a realist evaluation of social prescribing with time credits. And this is a collaboration between the University of Leicester, Cardiff University Centre for Trials Research and Bangor University, and is funded by Health and Care Research Wales. The study chief investigators are myself, Dr. Ceri Jones and Dr. Sarah Brand. Dr. Karen Pardy, Professor Mike Roblin and Dr. Mary Lynch are co-investigators. Hayley, Josie and Barry are our research associates. Lena is our project administrator. Jane Rees-Blaze is our social prescriber, and Amy Cole is our project partner from Tempo. The main study aim is to understand how social prescribing plus time credits delivered in primary care settings in Wales can have mental health and wellbeing benefits for patients, and also to get an indication of whether it can produce a positive return on investment. Work Package 1 is the Realist evaluation, Work Package 2 is the feasibility study, and Work Package 3 is the social return on investment.
Tempo time credits have been around for over 12 years, building local and national networks of organisations from across all sectors to encourage more people to participate in their local community. We do this through time credits. Time credits value and recognise the time given by people. For every hour given, you receive 1 time credit, which can then be spent on a range of activities in our network. We have an online platform where volunteers can see where they've earned and used time credits, as well as identify new activities. Organisations can also track and learn about their volunteers' activities, as well as understanding the impact and the value created. As you'll see here, a network of organisations spread across England and Wales. We modified our time credit model to be used in social prescribing as a hook, where time credits are an incentive for healthy behaviour. A participant is prescribed time credits by a designated professional, and together an activity is chosen, such as going for a swim with their children. Once a participant has used their time credits on that activity, together with the professional, with the social prescriber, they identify how best to earn more, encouraging future activity. Here we share the stories of two of our members, two volunteers who use time credits, Kelly and Les. They both found that time credits have helped them to break down barriers to volunteering, to getting involved in their communities, but also in healthy activity.
Jane is our social prescriber on the project. She is a qualified social worker with a vast local knowledge. She is based across 4 practices and takes patient referrals from GPs and the practice staff. Appointments are currently virtual in line with government guidance around COVID, and she collects baseline data at the initial appointments. These sessions, she uses goal-setting techniques such as SMART, trans-theoretical models of change, motivational interviewing and compassion-focused techniques, and patients are introduced to time credits and the time credit network, prescribed a number of time credits to spend, and then asked to set some goals for the next session. The Realist evaluation involves the development of the initial programme theory, semi-structured interviews with staff and patients, analysis of social prescriber notes, and stakeholder group consultations. The feasibility study undertakes a number of wellbeing baseline measures and a 4-month follow-up.
Work Package 3 is a social return on investment. Data that will be included in the social return on investment will be routine clinical data, which will take account of the number of GP consultations, home visits, triaging, and if there was any emergency admissions. In addition, this clinical data will include medication, including repeat prescriptions, depression scores, also the main referring condition and the length of diagnosis. Data will also include any chronic conditions, along with the patient's BMI, the number of minutes spent in physical activity per week, and patients will be asked to complete a question which will take account of the value that they place on the service, which will ask them their willingness to pay or the willingness to accept this new service.
Here is our logic model. I've talked to you about the inputs and also the research methods for the evaluation. Josie is going to talk in a bit more detail about the mechanisms and the contextual factors.
The main mechanisms are the interaction between the GP and the patient, the interaction between the social prescriber and the patient, the prescription of the time credit, the attendance in person or virtually to an activity and the social interaction with other users, and the spend of time credits and volunteering to earn more. The contextual factors are the fact that GP engagement will influence referral numbers, appropriate referrals which demonstrate an understanding of the study inclusion criteria, patient engagement in the process, the relationship between the social prescriber and the patient, the ongoing communication between GPs and other practice staff and the social prescriber, including feedback of outcomes, the availability of activities for earning and spending opportunities. This is especially important during COVID because the availability was a problem. The mode of consultation, so the fact that this is now virtually because of social distancing, that was a slight change, as we were hoping that the social prescriber and the patient could have in-person face-to-face meetings for the consultation. I'm going to focus now on some predicted facilitators and barriers. These have come from the mechanisms and context, as well as our staff interviews. Facilitators include the relationships and communication between the GP and other practice staff, social prescriber and the patient, and the flexibility of the approach of the time credits provider. Barriers were mainly focused on the COVID situation and lockdown, including that the intervention will be difficult for the patient to engage with due to not being able to meet the social prescriber in person, and a reduction in opportunities to volunteer and spend time credits due to groups and venues closing. Here are some quotes from our interviews. The first quote addresses the importance of keeping practice staff in the loop with regard to patient referrals, as the practice staff know the patients and build a relationship with them. This is one of the facilitators I mentioned. The second quote talks about how COVID created a surge of interest in volunteering, and the agencies responded well and adapted their work to take into account how things had changed due to lockdown. This is a response to one of the barriers I mentioned.
Thanks for listening.
So our next speaker is Matthew Cooper, and their presentation is going to look at identifying the active ingredients of social prescribing interventions targeting specific mental health, and this is a systematic review. So without further ado, I'll click on this presentation. Just to remind you as well, you can click on these yourself just in case this my end isn't working, but hopefully, fingers crossed, we'll get there this time.
Hello. I'd like to start by thanking the Social Prescribing Network for organising this conference and for the introduction by this session's co-chairs, Professor Wallace and Dr. Howarth. My name is Matt Cooper and I am currently studying for my PhD at Teesside University in my Stage 2 Health Psychology training with the British Psychological Society. Today I'm going to be giving you an overview of the work my colleagues and I have been doing looking at the active ingredients of social prescribing services and interventions. We decided to look at the active ingredients of social prescribing as previous systematic reviews identified that the evidence was mixed and lacked theoretical underpinning. The review focused on adults who had been referred either by primary care, secondary care, the third sector, or had self-referred to a social prescribing service or intervention. The intervention and services were based in the UK due to the differing health care systems around the world and the varying levels of need. We had a primary focus on mental health outcomes because we know that social prescribing is usually offered to those who are primarily presenting with psychological issues. As shown on screen, the URL for the protocol available on Prospero. To conduct this systematic review, we applied a search strategy to 9 databases, which presented us with 41,243 papers. And from the Prisma diagram, you can see how those results were narrowed down to the final 18 papers. Also included on this slide is the databases that were searched. And obviously from the Prisma diagram, you can see the reasons why full text articles were excluded. For the data extraction phase of the research, we designed a unique data extraction form that would capture data relevant to the demographics of the study, the social prescribing components used, the outcome measures that were applied, and the intervention components each study reported. To give you an overview of the included studies, the majority used an uncontrolled pre-post design, with the primary reason for referral to a service being anxiety and depression, and the majority of studies focused on a mental well-being and general health outcome, which were usually assessed by clinical questionnaires such as the Warwick-Edinburgh Mental Wellbeing Scale. Participants were on average aged 56 years old, and majority were female. There was a common lack of understanding between gender and sex, with a poor reporting of ethnicity, which restricts the application of a universally inclusive social prescribing service. The employment status of service users was grouped, as shown, and shows that the majority of service users were out of work, education, or position of responsibility. However, the proportion of which were in and out of work, education, or position of responsibility was smaller than previous research has suggested. There was an average of 51% lost to follow-up, and the average follow-up time was 3.96 months, although this did range up to 2 years. The most commonly reported reason for referral was anxiety and depression, as previously mentioned, with both reported together as the primary reason for referral in 39% of all included papers. Despite the focus on mental health outcomes being primary measure of this systematic review, we also captured the common physical comorbid conditions which can be shown on screen. Only one paper reported the use of a diagnostic criteria to assess mental health on entry to a service, applying the World Health Organization diagnostic criteria for anxiety and depression. Other papers use terminology throughout such as experiencing symptoms of, at risk of, or to reduce symptoms of, rather than these clinical assessments. The main finding of this review was the use of behaviour change techniques which applied a novel approach to understanding social prescribing services. The behaviour change techniques were coded by 2 trained reviewers and were coded using the Behaviour Change Technique Taxonomy version 1. The most commonly used behaviour change technique groups were goal planning, social support, and comparison of outcomes, and specifically the use of credible source and the use of social support were the most commonly used behaviour change techniques. The evidence in this area is limited by the use of uncontrolled before and after study designs, and we highlight the need for evaluation of social prescribing services to be planned in at the early stages of development. The application of appropriate behaviour change techniques could provide the theoretical underpinning that social prescribing services are lacking, and the use of techniques we have identified is promising, but more work needs to be done to test the combination of techniques which are best applied to each stage of this referral pathway. Finally, for social prescribing to be a truly inclusive service, there needs to be more research into how social prescribing can benefit all genders and ethnicities. Thank you for your time today, and I will hand back to Professor Wallace and Dr. Howarth.
Brilliant. So that was Matt's presentation, and I don't know if Matthew's in the room yet at the moment, but obviously he'll be here for questions at the end of the presentations. So I'd like to introduce the next session, which is actually Megan, Elliott and colleagues that have looked at developing a tool to measure social wellbeing in the context of social prescribing. Megan's in the room today, thankfully, just in case the link doesn't work, but it's all ready to go. So I will share my screen again and enjoy listening to this next presentation.
Hello, thanks Carolyn and Michelle for the introduction. I'll be talking about the study we completed to develop the concept of social wellbeing and a tool to measure it in the context of social prescribing. Wellbeing has many definitions. We use the general definition that wellbeing refers to what helps lives go better for people. Wellbeing involves both the mental and emotional states that a person experiences, as well as their social environment and ability to access and enjoy social resources like health, education, employment, housing, community assets, and inclusive and empowering social and relational networks. From discussions with the Wales Social Prescribing Research Network, we identified that mental and social wellbeing are distinct, and both are important for social prescribing practice. Developing a tool to assess social wellbeing will support social prescribing practice, monitoring and evaluation, and could be used in combination with measures of mental wellbeing to provide an overall picture of a person's wellbeing. We used a method called group concept mapping to undertake this study to develop the concept of social wellbeing. We invited participants to take part through gatekeeper organisations and recruited a total of 96 participants. Participants were invited to participate in 3 separate stages over a 7-week period. This firstly involved brainstorming ideas and generating statements in response to the focus prompt, which was, when I think of the things that have made up the social world over the last year, I include. In the next stage, participants then sorted the statements into piles and gave these piles labels. Finally, they were asked to rate each of the statements on scales ranging from 1 to 5 on importance, access and enjoyment. The majority of the participants were female, and we had a good age range from the participants, with an average age of 50 years, but ranging from 19 up to 90 years. Participants were predominantly based in Wales, but we had representation from England, Republic of Ireland and internationally, including Europe, America and Australia. 77% of participants reported not having a disability, and of those with a disability, we had representation from a wide variety of conditions, particularly those with mental health conditions. There was also a good split between the types of location that participants lived in, with good representation from cities, towns, villages and rural areas. In the brainstorming stage, participants generated 363 statements in response to the focus prompt. We completed a data cleaning task to reduce this to 125 statements, which was more manageable for the sorting and rating stages. Using the sorting data, the software generates a cluster map where it places all the statements as points on a map and then identifies a cluster solution. We agreed upon this 6-cluster solution, which identifies 6 clusters of social well-being. The first was everyday life activities and pastimes. This included statements like relaxing and creative activities by myself and enjoying the sunshine. The second is family and friends, including statements like reconnecting with old friends and sharing with friends. Third is connecting with others and supporting needs, including statements such as a large network of friends and getting to know the neighbours and chatting to them outside our houses. Fourth is community involvement, which is about things like seeing neighbours and offering them support and using local businesses. Fifth is engaging with and reflecting on the wider world, which is things like continuing to work after retirement age and using more technology. Finally, the sixth cluster is self-growth and security, which includes statements about being able to make worthwhile plans for myself and my future, and being able to put into practice worthwhile plans for myself and my future. The location of the statements and points on the map tells you more about how the statements were sorted by participants. Statements that were often sorted together are placed close together, whereas those that were rarely sorted together are located in different parts of the map. Using the rating data, we can understand how participants rated the statements within each of the clusters. The most important and accessible cluster was the self-growth and security one, whereas family and friends was the most enjoyable. You can see some differences in the ratings of connecting with others and supporting needs and community involvement on the different scales. These were rated as more enjoyable, but less accessible and important. We also looked at these comparisons for different groups, like males compared with females, or whether things change depending on the type of area a person lives with. But there were few differences, and the findings appear to be quite consistent across different demographic groups. Group concept mapping also enables us to create these maps called Go zones. These allow us to compare the ratings of different statements on two different scales, for instance, importance and access. By combining the data from the three maps, we can identify the statements that were rated as the most important, most accessible, and most enjoyable. These will be important for when we are identifying items to go in the social wellbeing scale. These include statements like living in a safe home environment, having a laugh, and the freedom to live my own life and be myself. We can also see statements that were rated as most important and most enjoyable, but least accessible. These included things like ability to travel, ability to meet and hug friends and family, and explore. The impact of COVID restrictions on these statements was particularly clear, and this has some important implications for the way that we think about social wellbeing in the context of the pandemic. We are currently using the findings to develop the South Wales Social Wellbeing Scale. This is an iterative process that will involve multiple stakeholders and multiple cycles to develop. We will then pilot test and validate the tool in practice, alongside the Warwick Edinburgh Mental Wellbeing Scale, the WEMWEBs, which a lot of social prescribers currently use. The development, validation and use of the tool will be ongoing, and we will amend and adapt the tool as the social world continues to change. We would be very interested to hear from you, or if you or your social prescribing practice would be interested in being involved with the pilot testing and validation process. Thank you for listening. If you have any questions, please get in touch via our email, and our full report of this study is available on the Wales School for Social Prescribing Research website. Thank you.
And I'd like to introduce our final speaker, who was originally our first speaker, Henry. If this link doesn't work, then what I suggest is we take a few questions while Henry emails me the presentation and we load it that way. So I'm going to go to the last one that Ben put in, the last video, and hopefully this will be the right one.
Hi there, my name's Henry. I'm a PhD student at UCL, and I was previously studying medicine, and I remember the first International Social Prescribing Conference a couple of years ago, and being really inspired coming away from that when I was still a full-time medical student and hadn't started my PhD yet. And so it's a real privilege to get the opportunity to speak here and present my research today. And thanks so much, Marie, and the whole team for setting up what is always a really fantastic conference. So I'm here to present a study looking at the barriers and enablers to effective social prescribing from a GP perspective for patients with mental health problems. And this study was done with Dr. Daisy Fancourt and Dr. Louise Baxter. So most evidence on social prescribing to date is from the patient perspective and their outcomes rather than specific implementation challenges. Various studies have shown the benefits of the link worker role to patients, and some from the perspective of link workers. But the role of the GP in social prescribing is less well understood, at least within the academic literature. But we do know there's lots of evidence from patients and link workers that the role of the GP is quite central. So we used a qualitative one-to-one interview approach informed by the COM-B model. And the COM-B model is a behavioural change framework derived from lots of different existing frameworks. and models human behaviour on our capabilities, motivation and opportunity. And we interviewed 17 GPs across the UK and used reflexive thematic analysis. So the codes were then grouped into themes, and each theme fell within capability, opportunity or motivation of the COM-B model. And after analysis, we applied the theoretical domains framework, which enabled the mapping of specific barriers and enablers identified by the COM-B model to types of intervention components that can actually help change behaviour. So this is our diagram of themes. So we've got the three domains of the COM-B model on the left, and then the blue boxes are the themes, and then the sub-themes within that. So the green boxes are enablers of effective social prescribing behaviour, the red are barriers, and orange is a mixture of both. So if we take a few examples here, if we look at the bottom, the sub-theme of demedicalisation. So GPs were actually really motivated by a desire to move away from the status quo in primary care, which they felt was failing many patients and leaving them with unmet psychosocial needs. We look at the top left, GPs talked about a range of interpersonal skills, including active listening, taking a personalised approach with patients, sticking with it or perseverance, and also the ability to get to the root cause of patients' problems as being fundamental to effective social prescribing from their perspective. We look at the top middle theme of trust and relationships. So GPs felt that patients had to trust GPs before they could overcome a sort of motivational threshold of agreeing to see a link worker or attend a community activity. And time, trust, and building these relationships should be seen within social prescribing viewed as a complex system. So it's necessary at all the different stages of social prescribing and with all the different stakeholders. We look at the bottom right, GPs cited a lack of formal evidence on social prescribing as being a barrier sometimes. Yet we do know there is a strong growing evidence base on social prescribing. So perhaps some of that evidence isn't reaching GPs as well as it should be. And indeed, when informal evidence was present, so when GPs were aware of how well patients were getting on with social prescribing, they were more likely to engage in social prescribing more effectively. And this corroborates wider research because it seems to be especially effective when there was positive feedback and reinforcement, either from patients or link workers. And lastly, at the bottom, GPs actually found social prescribing quite fun and rewarding to be involved in. And given the high levels of GP burnout and stress, this has positive implications for staff wellbeing, morale, and GP retention. So I'm just going to read a few quotes here from some of the GPs. So as a GP for 30 years, I'm very conscious that there are a lot of people that I cannot help with the skills and training that I've received so far as a doctor. There's no point just having somebody signposting if there's nobody there to signpost them to. There used to be quite a number of community groups going. There's very little activity there now. They're all gone. There's nothing really available. A lot of people that I see, 70% I'd estimate, are coming in with mental unhappiness, lack of mental well-being. That's the kind of stuff which is common in deprived areas, and it places a huge burden on practices. We medicalise unhappiness as depression, but does that mean they are actually depressed? They get medicalised, get given antidepressants, and get given neuropathic drugs, benzos, and opioids. Whereas in fact, when you drill down to it, it's because they've got no hope and no control and no agency. It's because they feel valueless. All the sorts of reasons which those drugs will never treat. I didn't have loads of time to go into all of these here, but we used the theoretical domains framework to propose various behavioural change interventions based on their evidence of effectiveness for particular types of barriers and enablers. So for example, we proposed a training package for GPs to develop the appropriate interpersonal skills for effective social prescribing, such as motivational skills, active listening, perseverance, and ability to get to root cause. Also at the bottom here, we proposed developing a system to provide regular, systematic, positive feedback for GPs on their social prescribing referred patients, and reward GPs who use social prescribing effectively and appropriately. Some more examples here. So for example, we proposed setting up a buddy system for patients, accompanying them to community groups and activities, and to use link workers and harness volunteers for this as well. So this is the first study to explore the barriers and enablers to social prescribing for patients with mental health issues from the perspectives of GPs from across the UK. So it highlights the needs to address barriers such as lack of formal training for GPs on how to engage effectively, the importance of a range of strong interpersonal skills, and the benefits of the link worker role. And further studies are encouraged to test the effectiveness of the behaviour change interventions proposed. So thank you very much for listening.
Thanks very much, Henry, and thank you for all the presenters today. They were all fabulous presentations, and apologies for the technical glitches, which are probably my fault mostly. So we're going to open up for questions in the chat room, but also I'll hand over to Carolyn at this point, because we thought we'd try and sum up the presentations, and obviously the presenters are here for you to ask questions. If you could post any questions in the chat room, that would be absolutely great. Hi, Matthew. That'd be absolutely great. But a huge thank you to all the presenters that all sent in pre-records and have all worked really hard. And there's some fabulous research out there. There's some fabulous learning going on today. I just have so many questions, but we'll hand over to the chat room and to Carolyn.
Hi everyone, yes, and I must say as well, thank you very much for your very interesting presentations, and I was very privileged last night to be able to go through those and come up with a little bit of a summary, because it's quite a blast, isn't it, having those one after the other. It's great to see a variety of methods, and your passion for your studies is quite evident throughout each of them. And I'm sure the audience here, we've got lots of questions that we want to ask. So please start, if you would like to, by putting your questions into the chat. So Matt's presentation on identifying the active ingredients and targeting mental health interventions, his systematic review it searched 9 databases, resulting in a final 18 papers. They identified that the majority of studies used pre-post designs focused on anxiety and depression, and used outcome measures such as WEMWebs. Majority of participants were female, and I think this is a theme, which I saw on particularly in 2 of the studies. He summarised by identifying that there are a number of findings, and in particular I picked out that evaluation does need to be planned early on, and I think that's a key message for everyone, and that a combination of behavioural change techniques needs to be further explored. I think there's probably a lot of work for you, Matt, in the future on this topic. Ceri presented the RESPECT study, a realist evaluation of social prescribing with time credits, how social prescribing plus time credits delivered in primary care can have mental health and well-being benefits for patients, and whether it can produce a positive return on investment. An interesting focus on time credits and their use as a social prescription as an incentive for healthy behaviour. I myself have a number of questions for Ceri and the team on the approach they're taking forward. Megan, developing the concept of social well-being in order to develop a new measure. An international study with a wide range of participants. Wow, a 90-year-old in that study, that's fab, isn't it? There were 96 participants, majority again were female, created a map of 6 clusters of 125 statements of social well-being, and were able to demonstrate the analysis with the other maps using the rating scales of importance, access and enjoyment. Henry, what are the barriers and enablers experienced by GPs to engaging in social prescribing for individuals with mental health problems? A qualitative one-to-one interviewing approach, 17 GPs across the UK, and using a reflexive thematic analysis. Now, that was a really interesting, I think, focus on GPs, because the focus has been very much on link workers per se. But to recognise that, this piece of work for GPs is quite important for us in order to set the context and enable link workers to be set within the context of primary care. And of course, he comes up with some really fabulous findings. Specifically, I note around the lack of formal training for GPs. How can we expect them to know what to do, without having some training? So there we are. Now it's your time to ask questions. We have a couple of questions that in the chat here. One from Kiz. My question is really about the knowledge gap in GPs and the way creativity helps heal trauma. So that's not necessarily a question, but I take it back to Henry and the knowledge gap with GPs. Was there anything about creativity and within the articles that within the study that you did?
Yeah, I can have a stab at both of those very briefly. So in terms of the knowledge gap, it was certainly something we identified in the study. GPs felt that both formal evidence was lacking on social prescribing, but actually we do know there is a really strong evidence base and a growing evidence base that social prescribing can support patients. So maybe it's actually a lack of that evidence reaching GPs. And then the other thing is, you know, as a medical student, I'm taking a bit of time out at the moment, but medical syllabus for medical students is still very biomedicalized. And actually, if you ask first-year students what they want to become as a doctor, the vast majority of them still say a specialist doctor in hospital. But actually, you know, 50% of medical students will become GPs. So we need to challenge that from day one in medical school, I think, and bring in more things like social prescribing medical school syllabuses, which groups like the student social prescribing scheme are doing across the country. And then in terms of the creativity question, I'm not sure if this is answering it fully, but a number of GPs did talk about how it was really fun to engage creatively with social prescribing. Actually, it was quite an exciting thing to be involved in their practice, and it brought something new. It gave them something to offer patients, and it was just fun to create those new relationships with you know, local community groups. And I think that's a good selling point for social prescribing, especially in terms of the context of higher levels of kind of GP burnout and things like that at the moment. So in terms of GP retention as well, I think it's important. Thanks. Thanks,
Henry. I think it's a good point, isn't it? Not many of us can say that we're having fun in our jobs these days, and it's been a very challenging time. But if GPs can feel that they're having fun with social prescribing, that's good for me, I think. Now, Eddie's got a question here about how can we recruit more men to the studies, and I'd like to open that up to Megan, please.
Yeah, I think it's a really good question and not an easy one. I think we need to think about who we're going out to. So I know personally in my study, we went through a number of networks, and I think that the membership of those networks were predominantly female. I think we need to think about the incentives that we offer and the way that we present our research, but I don't know whether anyone else has any other comments related to that as well.
What about you, Matt? Have you seen anything in your studies around engagement with men?
Yeah, I think when we looked at the data, that there's just a lot of services when they're evaluating, a lot of the evaluative work is predominantly with females, but also it's understanding, I think, the gender role in social prescribing, and I can't come to a conclusion on that because there's not enough data to suggest either way, but actually how that spans across the gender spectrum rather than just let's classify them as males and females is actually what else is there, what more do we need to understand to be able to offer a fully inclusive service. And I think we need to kind of capture that data a bit better when we're evaluating services in understanding what impact we're having, because it is person-centered. So if someone necessarily doesn't identify as a specific male or female, then how does that affect their pathway and journey through a social prescribing service? So I think we also need to kind of take that side of thing into account as well.
And Ceri, what about inclusivity and time credits? I mean, that's an interesting concept, isn't it? Time credits, using it as an incentive. Have you seen any differences, or do you suspect that you may have differences in the take-up of time credits and different times of time credits?
Yeah, so we don't know yet because we've only got a small number of participants in the study. But yes, I suppose the underlying theory around time credits or time credits within this particular study is around reciprocity theory. So if you give something, you're much more likely to get something back. So the participants are prescribed time credits. So this is an alternative currency that they can spend across the network. So as I said, they've incorporated new things, Netflix, Tesco's food vouchers, for example, and then they're encouraged, there's no obligation, but they're encouraged to earn back. So through volunteering across the network. So there's lots of things that has been shown to improve, such as pathways to employment, etc. And certainly that is happening with certainly one of our participants who is on second interview. So I suppose it's an added layer of incentivising or motivating participants if that is suitable. But the reason we're doing a realist evaluation is to understand which participants this is most appropriate for.
Thanks, Ceri. And there's a lovely question here from Jane Sutil. How can we make this excellent research more accessible to those setting up or running social prescribing services so they can engage more effectively with evaluative methods and build them into their programme design? So shall I go to you, Megan, again? Do you want to give us your words of wisdom on this one?
Sure. So, I mean, I think as researchers, we tend to focus largely on those publications and getting our reports out, but I think we actually neglect a massive aspect of dissemination, which is dissemination to the public. So I know in a number of other projects that we've done, we've worked on creating things like dissemination videos. So we've had an artist do some graphic drawings at the same time as a voiceover. And I think things like that, keeping it quite snappy and, you know, a minute long dissemination of the general ideas and then sending people signposting to the right direction if they want more information is a really good way of sharing that best practice. And absolutely, as the question wrote, you know, starting that process really early on and getting people engaged at the start of the evaluation will definitely encourage the stakeholders to be more involved and really shape that evaluation to be really strong and produce some robust findings.
I can see you nodding your head, Ceri. Do you want to add to any of that?
Well, no, actually, I'm doing another piece of research around men's mental health in first responders. So yeah, there is. It's definitely really important to engage the recipients of your research very, very early on. And that's what we did with our stakeholder consultations. And we had some fantastic feedback, actually, from two of our patient representatives, one male, one female. One male was saying, actually, what is this? I don't understand what you're talking about, which was great because, you know, he was potentially going to be our future recipient. So if he couldn't understand what we were talking about, then how on earth were we going to get patient referrals? So that was really, really helpful. So I definitely think engagement at a very early stage around the kind of language, terminology and messaging. And also I think this outreach is really important. Why should we expect them to come to us? We should go to them. Yeah, so I agree.
Thanks, Ceri. Henry and Matt, do you want to make comment, or shall I move?
Yeah, I'll obviously Henry's done a specific part of social prescribing, but where we were at when we were looking at the behaviour change techniques is actually Henry's probably taken a bit of what we've done a bit further in applying certain techniques to, for example, the GPs and how using the behaviour change techniques to help the training and help develop that skill set. Well, great for the GPs, but we now need to look at how do we apply that in other stages and throughout the social prescribing pathway. And to do that, to be able to, for social prescribing services to apply, we need to kind of develop that a bit further. We are at a great point. Henry's work is started that definitely and looked at that GP training scheme. But it's now about how can we apply that all the way through, I think. I don't know if anyone wants to say any more on that front.
Yeah, just that there is that GP study was actually part of a wider group of studies that do look, not that I was actually primarily involved in, but that do look at applying those behavioural change theories to the community group stage and the patient or citizen stage. So there's a very similar model study for the community group stage that does focus groups of community groups, but applying that behavioural change model. And there's also one from the patient perspective. So I'm happy to point people in the direction of those if they're interested. But I think just we need more research, as you say, that's appreciating social prescribing as that complex system and that pathway, and having that kind of data at each stage of the pathway.
Thanks very much, guys. And we've only got a couple of minutes left now, but there are some quite interesting questions in the chat, and I wonder if you four of you take the opportunity to answer some of them. But there's one in particular, well, two in particular about knowledge gaps. One is for you, Henry, around the is it the lack of evidence reaching GPs, or is it just not presented in a way that they take notice of? So I wonder if you could take a look at that question. But there's another one as well as knowledge gaps. Now this is Katie James. How do we start to shift the cultural challenges that exist specifically in primary care? I think that's a big question. Anybody want to take a go on that one? Or do you want to start with the GP one, Henry?
I'm happy to very quickly start on that. I mean, I think it's interesting to split up evidence into kind of informal evidence and formal evidence. And certainly the formal evidence hasn't been reaching GPs as well as it could have done. Just a lots of, both that study, but also just lots of conversations I've had with GP trainees. So there is that side of thing, and that does need to happen in medical school as well. But there's also a need for a more increase in informal evidence. So having good feedback mechanisms back to GPs on their social prescribing referred patients. Because a lot of the time GPs don't actually know what happens to patients. And if they get better, GP might think, okay, that's great, they don't need me anymore, but they don't actually know. And there's often not a very good, from what I understand, there's not a very good feedback mechanism in how certain patients are getting on broadly in the health service, but also within social prescribing. And I think if we try and harness that informal evidence and feedback more in terms of just very rigorous feedback mechanisms, and the link work can obviously be crucial in that. It just incentivizes GPs to refer people more, gets them more passionate about it. It's a mixture of those things.
Thanks, Henry. And it's 3 o'clock now, Michelle, and all I've got to say is, and thanks very much to everybody for joining us this afternoon in this parallel session, and to our 4 speakers who have sharing with us their wealth of knowledge and their fantastic studies. I wish you all the very best with them and look forward to hearing more about them in the future. Make sure we hear about them. We can't wait. Thank you.
Thanks very much, everybody. And just remind everyone that the links are in the chat room. So if you weren't able to see the slides, you can get the links and copy them and watch them later. Thanks very much, guys. That was totally fabulous presentations by everybody and some fabulous questions. Thank you, everybody.